Okay, welcome to another episode of Machine Medicine's interview series on neuromodulation. We're delighted to have Vicentzo Levi here with us today, who is a consultant neurosurgeon at the main hospital in Milan. And thank you for being with us, Vicentzo. And as we mentioned, we always like to hear a little bit about your background and how you got into this fascinating field. And so perhaps you'd be so kind as to tell us a little bit about what brought you to this place.
Yeah, and first of all, thank you for the invitation. It's an honor to be with you today and speak about functional neurosurgery, which is actually my main interest in my job. I currently am a consultant neurosurgeon at the hospital St. Charles in Milan. I've been interested in functional neurosurgery since I started my residency at the Neurological Institute Carlo Besta. At the Neurological Institute Carlo Besta, I had the chance to stay with a lot of very famous colleagues. First of all, Dr. Angelo Franzini, who is in Italy like a certain institution in functional neurosurgery. He taught me a lot of things about this subspecialty and how to do DBS for Parkinson's disease, for dystonia, and for other neurological conditions which are maybe more rare, like neuropathic pain or failed back surgery syndrome. And so I moved from the Neurological Institute Carlo Besta 1 year ago. And actually, I'm moving back because I'm in a sort of translation. In a couple of months, I should go back there and start a program of functional neurosurgery there.
Fantastic. And so it's always interesting, especially when speaking to neurosurgeons, because obviously neurosurgery is a much broader field than just functional neurosurgery, and arguably in the neurosurgical community, there's an attitude, at least from some, perhaps uncouth and old school neurosurgeons, albeit that functional neurosurgery is somewhat sort of somehow not the real thing, and just doing little craniotomies and not really getting involved with bleeding aneurysms and that kind of stuff. So what was it to your mind that when looking at all of the different subspecialties made you think actually functional neurosurgery is the place where I want to dedicate the main part of my career?
Yeah, you're perfectly right. You got the point. I mean, when you start to do a residency in neurosurgery, the majority of people, they are there just to do very tough things like vascular neurosurgery or oncology, like doing craniotomies all day long. And while to be a functional neurosurgery is a little different because we do not do such kind of tough intervention. Our surgery is very basic if compared to vascular neurosurgery, for example. But the main reason I choose when I started my residency to do this field, this very subspecialty, it's very small if compared to the entire neurosurgery, is that I'm a kind of neurologist. I mean, I really like neurology and neuroanatomy. And the idea of modulate some networks in the brain which are not damaged but are dysfunctional by means of electricity or other kind of intervention which are very minimally invasive. It's something that passionated me since 5-6 years ago when I started to do this job. And maybe we are considered sometimes like a nerd in the field of neurosurgery, some weird people, but I guess that the future of neurosurgery is in part the functional neurosurgery, because we are going more and more towards a future where we can achieve with this electricity or other kind of energy like ultrasound very great results with skinless surgery, with very minimally invasive surgery. And so it's the future. And a lot of colleagues of mine are starting to think the same. They are some kind converting to this kind of surgery, and so this is great for me.
And one of the other interesting areas I came across some time ago is actually the application of, as it were, neuromodulation to the oncological field. And actually, there's some very interesting research now being developed into real clinical tools, which is based on the idea that you can use electrical currents in order to inhibit metastasizing and dividing cells, and actually, treat some oncological conditions. So there's some fascinating applications which may not have been obvious when the field first emerged, I suppose. So
yeah,
I'm sure
we are not still there, but the oncological field is something that we are starting to discover as functional neurosurgeon. But today, for example, I do a lot of functional neurosurgery with ultrasounds, and this is another great possibility for the future, in particular for the oncological field, because I think in the next year we could burn, damage brain tissue, even pathological brain tissue like tumors, without do any kind of incision, without using the knife to do that.
Non-invasive in that respect. Yeah. So, well, that gets us onto an interesting sort of question. And I noticed some of your previous work has been on looking at, as it were, sort of lesional interventions versus kind of, what would you call them? Sort of neuromodulatory interventions.
Electrical therapy. Yeah,
exactly. So what are your thoughts on this? Are lesional approaches just sort of the best that we can do today? Would you see those ultimately being left behind, or do you think there'll always be a place for lesional kind of approaches?
This is a strange story. This is why the field is so fascinating to me. So in the 60s, the main application of functional surgery was lesioning. Before discovering the pharmacological treatment for Parkinson's disease, for example, functional neurosurgeons treated the Parkinson with the ablation of some brain nuclei, like the thalamus or the globus pallidus internus. Then it came the DBS, which is the electrical therapy, which is of course less invasive than damaging with lesioning, and so a lot of people thought that the era of lesioning in functional surgery was to be finished very soon, and in the recent years, this kind of mentality has changed because there are a lot of reasons to choose lesioning instead of electricity to treat some pathological condition. You have to imagine that it's not always feasible, and most of all, in particular in the developing countries, having like a DBS system. It's very expensive. It costs a lot, and also there are a lot of complications, like infection, which can be very devastating for the patient. Doing a lesion, it's totally different. You cannot have infection at all, and you do not have to spend a lot of money for neurostimulator or for the leads that you put in your brain. So it's in some situation it's very advantageous. And with the advent of ultrasound, this technique is becoming very popular along the world, because ultrasound is another way to do a lesion in the brain. And if in the past we had to use a catheter to do a lesion, today we do not need any kind of catheter. We just need a stereotactic apparatus and MRI, and we can check online the lesion by seeing it in the MRI.
Right. So even the surgical planning can kind of be done remotely, and then you can
Absolutely,
have
yeah.
Perhaps an operator who may not even be a neurosurgeon doing the actual procedure.
We actually when we do this kind of surgery, we stay in another room with our MRI monitor in front of us. We plan the treatment the day before, and we can see in real time what's going on in the point we have chosen to do the lesion, like the temperature of the brain in that point. And we know that after 60 degree, there is a lesion, and the patient is awake, so he doesn't need any kind of anesthesia. And we can check the result immediately, like a switch on-off mechanism, because when the lesion has been done, usually the patient, for example, stops to have the tremor. And this is a great thing that you can achieve as a doctor.
Fantastic. Okay, I mean, so the jury's still out on whether or not Legional approaches will have a future. Certainly, it seems like today, for the reasons that you've given, such as the reduced risk of infection, reduced cost, there's still a very real place for lesion-based approaches. But I'm keen that we should get on to sort of the meat and veg of your sort of current interests, and in particular, you I believe are interested in movement disorders. Is that right? And have published several papers, and we're going to talk about some work that you've done in a second on the STN. And maybe we could just say a little bit about the STNs, the prevalent, the most common target in DBS surgery for Parkinson's today. How did we get to that? What were the other candidates, and why do we alight upon that one?
So historically, actually, there were a lot of other targets, like the globus pallidus internus, the thalamus, which are part of the same great brain system, the basal ganglia system, which is a system of subcortical nuclei that control mainly the coordination and the movements of your body. And when they are dysfunctional, they can generate some aberrant network, which can produce abnormal movements like tremor or dystonia, which is dystonia is a fixed posture of your body. And at the beginning, the globus pallidus internus was the most chosen one for historically, because the first treatments were made there. Then in the 90s, the group of Benabid from Grenoble discovered that stimulating the subthalamic nucleus can produce with high frequency, can produce an arrest of the tremor. And this group then tried to apply these results in the Parkinson disease with very good results. Today, the subthalamic nucleus is I guess, the most popular one, the most prevalent in terms of targeting along the world. Even though I have to say that I spent almost 1 year in the US working at the UCLA. And there they
I was just going to say they target the globus pallidus, right?
Yeah, they do. It was like very surprising for me coming from Europe, because we are very like we have this legacy of the Grenoble group, and in Europe we almost do the same. So the DBS and the STN. In the US, I was very surprised, because they actually do like a more personalized DBS. They see if the major components of the symptomatology is tremor, they maybe do more STN. But for example, if the patient has more like levodopa-induced dyskinesia, which are the movements that can be produced after a long therapy with levodopa, they go actually for the GPI with great results. And because, there is also a controversy about the electrical stimulation of STN, some believe that it can produce after a long period of therapy, like some kind of problem with cognition, while GPI is not so involved in cognition. So there is this controversy, but I would say that STN absolutely is the most popular one.
Yeah.
And it's very standard target today. So it's everyone knows how to target and which would be the complication of targeting it, and that's it. Yeah.
Okay. Yeah, I guess this is one of the reasons why sort of big databases and registries and so forth are necessary for us to try and work out some of these questions. So, but given that the STN is the primary target, perhaps you can say a couple of words about what are the sort of surgical challenges about actually hitting it? For example, it's very small, right?
Yeah, it's very small. It's like 8 millimeters cubiscus, and the main challenge is to do the things right when you plan how to achieve the target. I mean, you have to be very careful and see with like a kind of obsession the MRI of your patient. And there are different strategies that you can use. The oldest one is using some reference in your head, which are the anterior and the posterior commissure. And this is called the indirect target. You use a stereotactic atlas, and it's like, you have to get your coordinate in the brain starting from seeing this point on the MRI. And there is the one I use, the technique I use today is different. I hit the target directly seeing the MRI. So today we have a very good MRI imaging at 3 Tesla imaging. And from this kind of image, you can see the STN perfectly. And you can target directly on what you see on MRI.
Right.
There are some kind of complication, but you can avoid them by seeing very well the MRI, like hemorrhages, but you can plan your trajectory to get to the STN and avoiding the small vessel along the trajectory, so reducing the rate of hemorrhages.
So are you doing it awake or in anesthetized patients?
Yeah, this is a very interesting question, because there is an ongoing debate about the possibility to do this kind of surgery also asleep. I currently do awake. Do awake because I've been taught like this, and I feel very confident to do this kind of surgery awake, because you can have a constant feedback from the patient. If there's something that is not going well, you notice it immediately. But there are some new technologies like intraoperative MRI or intraoperative CT scan, thanks to which you can immediately check if you hit the target correctly. And this kind of technology, I guess, in the next future will change the game. And I can say that in the future I imagine more asleep DBS than awake DBS, mainly because the patient, if you choose the patient, I guess that the patient will say to you, "Doctor, please, I would like to sleep and not to be awake," because it's a long surgery. It's like 6-7 hours of surgery, and it's very stressful for the patient. If you can do this safely with the patient sleeping, I guess this is the best solution.
Got you. Well, that's very interesting, but it does rather then ask the question: if you can either do it with an image-based approach and a sleep patient, and even intraoperative imaging now, or you can have an awake patient and see the clinical feedback, and then why would one also need a microelectrode approach that you've also worked on, where you're using electrical signatures in the neuronal populations in order to identify when you're in the STN? So where does this come into play?
Yeah, actually, if you plan to do this asleep with an MRI, theoretically you should you couldn't do without any kind of electrophysiological monitoring. But electrophysiological monitoring, like the microelectrode recordings, are very interesting for two kind of points. The first is that as functional neurosurgeon, we do operation, sure, but we also explore brain. I mean, this is an incredible, unbelievable chance to know how our brain works, to get signal from it, and to know, for example, what lie behind your movements, the way you plan your movements, the way you decide to do things. And the microelectrode recordings are a great possibility to explore this kind of mechanism. And the second reason is that STN, for example, has a very typical electrophysiological signal markers, and when you get there, you can be sure that you are 100% in the STN with microelectrode recordings. Today, there are other kind of signal that can, in the future, substitute microelectrode recordings, which are local field potential. Local field potential are a sort of EEG of subcortical nuclei. So they can feel the signal from a lot of neural cells, not just one, like in the microelectrode recordings. And this is very interesting for us.
Yes, yeah, I see. And that's a local field potential that you can record from the actual device itself now, or do you mean you record from a separate electrode?
No, we are today. We are very lucky. We can do both. We can do the registration during the surgery, and also we can. There are some new neurostimulator available.
The Percept device.
Yeah, the Percept. Not because we are working with another company, which actually was the first to believe in this kind of technology, which is Neuronica. They have this kind of adaptive stimulation in which the neurostimulator can feel your brain activity, and when your subthalamus is in a range of low beta frequencies like 10, 30 hertz, this neurostimulator can give you stimulation just when you need it. And so this is very advantageous mainly because you can save a lot of battery from the neurostimulator, and then it's a very adaptive stimulation. It's a personalized stimulation for you, for the patient.
Yeah, I believe they have a large trial. They have a large trial ongoing at the moment. So are you part of that trial?
I've been cooperating with them with their preclinical studies on animals. But now I can't do this kind of anymore because in Italy it's forbidden to.
Okay. Yeah. Still a fascinating technology. I agree. The one of the things that you explored in your paper on intraoperative feature-based classification of microelectrode recordings to support subthalamic nucleus functional identification was the use of algorithms in order to analyze those electrical signals and identify when you're in the subthalamic nucleus. I guess there's no reason why the same approach couldn't or shouldn't be used for local field potentials. Is that a fair comment?
Yeah. First of all, let me say that this work was born after I saw in the US that there is a need for collaboration between surgeon and engineering, because our field is so technological now, and we need their support to do things like that. We have tried to classify some neural features, microelectro recording features like frequency, like time domains, and we have tried to see if there are some features that can predict that in that moment we are surely in the STN. And this was the first step. This is a very interesting collaboration with the Polytechnic of Milan, and was the first step to design a machine learning algorithm. So a sort of intraoperative system that can assist the surgeon and say to him with kind of with a sort of probability if he's in the right place or not. Like you are in the STN with a probability of 80-90%. And this could help in the future the surgeons to be more confident with their surgery.
And so, in your paper, you actually outline a sort of schematic, figure for how the system should be constructed. So, what are the main impediments stopping you from actually having this system? Is it regulatory approval, or is it technical? What are the...
No, actually, no. There aren't any kind of this problem with regulation. In our mind, it should be like a simple software. Software that could be downloaded or installed on your intraoperative laptop. And this kind of software can just say to you if you are doing the right things or not, if your target has been hit or not. So in my mind, it's something very simple. It's nothing that can obstaculate the normal surgery.
Yeah. So what? That's my question. Though, if it's so simple, why doesn't it exist?
No, actually, the main companies are trying to develop and are trying to put on the market this kind of systems. So it's not so an idea out of a blue, but it's something that is good known. And the problem is that you can certify the accuracy of the system. So you need a lot of numbers, a lot of data. This is a real big data problem, and to do this kind of machine learning. And the big companies have more chances, more possibility to do that, because they are bigger. And when you do basic research like this with the university, it's not so easy.
Yeah, I mean, I think one of the other points I think is that actually this represents only one source of data, right? I mean, you mentioned as well that you can actually get, especially if you have an awake patient, you can get clinical feedback. Actually, have they got a good clinical response? And ultimately, that's really what everyone cares about, right? It doesn't really matter how beautiful your EEG is or anything else, or even your MRI. But then on the other hand, you've also got anatomical information, as you said, from your sort of your high resolution 3T MRI, and maybe even higher now at some sites. Some sites I believe have up to 7T available for clinical use, which is fantastic. So, you know, and I think that's another layer that's required here. Would you agree that we need to be able to integrate these data sources, as you said, if you really want ultimately a probabilistic kind of estimate of whether or not you're really in the STN, and you want to incorporate all of those different data sources, right?
Oh yes, surely. And the next step of our project is actually to integrate this information, this electrophysiological information, with the reconstruction, the postoperative reconstruction of our leads. Wow. Today there are a lot of free sources software like Lead DBS, which runs on MATLAB, that I personally use every day. And you can reconstruct your leads in the 3D space and match so the accuracy of your targeting with the accuracy of your electrophysiological signals recorded intraoperatively. So DBS technology, as you say, it's becoming a big data field. You have to know that you have to be a good surgeon, but you have also to know how to integrate different data, radiological, electrophysiological, and clinical data to ensure the patient best outcome. So the future is this.
Yeah, I couldn't agree more. Vincenzo, it's been a pleasure. I'm conscious that we've come to the end of our allotted time, but it's been great to talk to you. And I think that's the first time I've met a neurosurgeon who's willing to confess that he secretly feels that he's a neurologist.
I mean,
always a pleasure.
I'm trying to do my neurosurgical practice always with the mind, with the neurological problem. So the clinic is very important to me. There is the patient and then the surgery. Yeah.
Agreed. And yes, a pleasure to talk to you. I do hope we'll have an opportunity to catch up again sometime.
Yeah, sure.
And speak again. But for now, thank you very much, and look forward to speaking again in the future. Bye now.
Yeah, thank you. Take care.